Hello doctors. In this video I'll try to pass by a few tips that we should always remember in doing our job as pediatricians, and these tips are related to pediatric ophthalmology practice. Let's start by enumerating topics to be discussed in this video. I'll start with what we have to search for in a normal newborn. Second will be what about the red reflex and what's its importance. Third topic will be how can I assess visual acuity in a normal child. Fourth, what about nasolacrimal duct obstruction and what are the common pitfalls we usually meet in our practice in pediatric ophthalmology. And last one will be how to assess for presence or absence of strabismus in a child. Let's start by how to assess a normal baby. Usually, for doctors attending labor, they are waiting for the child or the newcomer to search for what about his breathing sounds or heart sounds. Is there any skeletal deformities? Has he any abnormality in his chest or abdomen? What about his head circumference? What else I can search for? But taking care of good eyes will be very simple using a pen light torch or any source of light to make sure he has normal eyes. This is the shape of a normal eye. We have to check for clarity of the cornea. Pupil is round, regularly active. Both eyelids are normal in position and shape. What about the color of the whiteness or the sclera of the eye? These are the normal findings I have to search for. In these cases, if you looked at that case on the left hand, you'll find this baby has a completely normal right eye. But on the left side of the same baby, you will have complete drooping of the upper lid. This drooping is called complete ptosis, and this ptosis may obscure the visual axis. And if it's left like this in the developmental period of the first year of life, this patient will be blind forever because he will develop what we call lazy eye or amblyopia. Even if you went for successful treatment later on, actually he lost much of his vision in this developmental period. So this finding is very important to search for and to refer as urgent as we can to an ophthalmologist to find a solution. It's more complicated than the other one because this child has bilateral complete ptosis. This is another anomaly of the eyelid. It's called lid coloboma. Coloboma means the defective part of the structure. So lid coloboma, like in this one, may be complicated by having a problem in the tear film production, health of the external surface of the eye. But another problem with having a lid coloboma is having an association of a systemic problem. So if you find any case with lid coloboma, you have to call for ophthalmological consultation to search for any association with this problem of lid coloboma. Some other abnormalities like this one. This is called dermoliboma. Dermoliboma is one of the benign swellings on the surface of the eye. It's like hamartoma, but it may affect vision by causing compression of the cornea and causing what we call astigmatism that may affect vision. So it should be treated if it's endangering vision. But if it's safe to leave it, if there is no astigmatism or no obscuration of visual axis, we can leave till the child grows up and we can remove later on. So this decision should be taken by an ophthalmologist and we have to take care of this shape. It's called dermoliboma. Some other complicated or more complicated cases like this one. This is what we call a sclerocornea because we have a cornea completely opaque like the sclera, and in such cases light is not going in the eye at all, so this child is not seeing, and this problem can be in some cases treated surgically. So if we found this case, we have to refer to an ophthalmologist. One of the most common problems in pediatrics, having large globe with cloudy cornea that we can call congenital glaucoma or ophthalmos. It may be unilateral or bilateral. So searching for the globe size, if we compare this eye size to the other one or to the original eye, the normal one we saw in the first picture, you'll see this is a very large globe, huge sized globe with congenital glaucoma, and sometimes it's urgent to treat by the age of 1 day. So sometimes we are admitting these cases for surgical intervention as early as we can to save the cornea and optic nerve of the eye. This is a more complicated case of ophthalmos or cloudy cornea with congenital glaucoma. In the left eye of this child, it's completely opacified cornea with large globe, and this child should go for surgical intervention to save the eye. Other anomalies like this one, we have microphthalmia or a smaller globe like in the left eye of this child. It's a mal-developed eye, smaller in size, with worse vision, and it may be associated with other findings like secondary glaucoma or retinal structural defects. So if we are dealing with a child with a smaller eye than the other one, we have to refer to an ophthalmologist to search for associations or to rule out other vision-threatening conditions. It may be more advanced if we have completely absent eye, like in this child with absent both eyes. It's called anophthalmia. Second topic to discuss is assessment of red reflex. What is the red reflex? It is the reflex generated from the interior of the eye when we focus by a bright light from a distance 30 to 50 centimeters on both eyes to compare the brightness, equality, and distribution of the red reflex in both eyes. This one has good, bright, equal red reflexes in both eyes, but the other one with the right eye normal, having good, bright, central, well-distributed red reflex compared to the dim, black one in the other eye. Actually, it's a very important test to check and very easy to do using a direct ophthalmoscope, which is very cheap and may be available in all hospitals, just to compare the shape of the red reflex in both eyes. Let's compare these patients. This one has good red reflex in the right eye compared to the a bit yellowish one in the left one, and this is a completely white reflex in the left eye. We have a dim reflex in the right eye and completely absent black reflex in the left eye in this patient. This patient is showing what we call leukocoria or white pupillary reflex in both eyes, and this one is showing whiteness of the peripheral part of the reflex in the left eye and actually very dim red reflex in the right eye. Actually, if we revise the causes of the red reflex deficit, we will find a very long list of causes, starting from hamartomas, structural anomalies, detachment, cataract, but the most important of these causes are these 5. It may be due to refractive error in high myopia or high hypermetropia or high astigmatism. It may cause defective red reflex. Sometimes in strabismus that we call Bruckner test, cataract that causes whiteness of the pupil, retinal detachment, either rhegmatogenous, exudative, or tractional, and the dangerous retinoblastoma. So by using our red reflex test, we are just ruling out many serious and common causes that we can save lives if we can diagnose at the proper time. So it's very important for these examining newborn babies, especially after delivery or in the few visits in the first few months of life, to check for red reflex clarity and diagnose any abnormality and refer when possible to an ophthalmologist to detect the cause and search for the proper management plan that may save life. It's very important. Our third topic to discuss is how can I assess vision of the child and how can I detect if my patient is seeing well or not. Before going to how to assess vision, let's start. We all know about developmental milestones of the child. Like we know very well, he's supporting his head by the age of 3 months, and he can sit without support at the age of 6 months, and he can creep by the age of 8 to 9 months. Then we can tell this patient is defective or of having delayed milestones if he's not walking till the age of 2. But what about the visual development? And how can I detect if my patient is going well regarding his vision or not? Usually the normal child at birth is seeing 20/400, which equals just looking at shadows or very bright light. By the age of 1 month, he can look at pictures with contrasting black and white, and he's blinking to approaching near objects, and this is very important. We'll tell later how to examine according to these milestones. By the age from 2 to 3 months, he can start to see objects as one image, like he has seeing a tree like one image, or the TV is one image. He can look at his hands or at showing hands. He can follow light, faces, objects. By the age of 4 to 5 months, he can start staring at his own hands. He can look at himself in the mirror, and he stares at blocks. By the 7th month, he has full color vision development, and he can see well at longer distances, and he can start to pick up a toy if it dropped down. From age 7 to 11 months, he stares at small objects. He starts to have depth perception and seeing the third dimension. Age from 11 to 12 months, he's watching rapidly moving objects. By the end of the first year till the age of 14 months, he's able to place shapes in the proper hole of the puzzle. So, how can I examine the child to assess for vision if he's seeing well or not by the age of first month? First thing is pupillary reflexes, using our pen light torch to focus at the pupil to detect is it contracting the pupil reflex rapidly, regularly, in a rounded form or not. If we have brisk pupil reflex, it's contracting well and it's round, regular, reactive, so it's seeing light. The pupil reflex starts to develop by the age of 31st months of gestation, and it's fully developed by the age of 36 weeks of gestation. So if we have a premature baby by the age of 31, 32, or even 33 months, we can't judge his delayed pupil reflex or not. By the age of first month, the child can be examined with dazzling reflex. Dazzling reflex we can use using a very bright light of a pen torch in a dark room, then shining at the child's eye with the bright light. If you start to clench his eyes or to close his eyes in response to the high illumination of the light, so he can see well. This is the dazzling reflex. One more test is very important. It's called eye popping sign or eye popping reflex. If we are in an illuminated room and illumination around is very nice, then we close all lights. So the child will find him in a dark room. So he will start popping of his eyes. He will suddenly opens his eyes or retracts his eyelids. This is a very important sign to detect in a child in a dark room. It's called eye popping reflex. From age 2 to 4 months, we can start assessment of the visual child vision by showing colorful objects, especially if large, and we can move them. He will start following our objects by the week 6. Then I can assess for vision by larger objects. Then if he's seeing well, I can test with the smaller minims or smaller objects. One very nice test is head rolling test or doll's eye maneuver. If we are focusing at the child by the age of 4 months with any colorful object and we are trying to just move his head from side to side, if he's seeing well, he will keep fixing his eye on the object. So what I can see, I am moving his head and he's still keeping the eye contact with the object I'm showing with. After 4 months, we can assess for fixation because myelination is much better in the fixing nerves. So I have to search for central, steady, maintained fixation on objects. If I am showing at the child with an object who will have central fixation, like in this one, you will have steady fixation and it will be maintained, and this means vision is better than 660. After 6 months of age, we can assess for visual acuity of the child using the optokinetic drum. Originally, this is a drum that can be rolled around and these stripes are moving. The child will fix a certain line, mostly a black one, and he will keep following the black one till it disappears from his vision. Then he will come back to fix another one. So what we can see is like in this one. He will just keep following one object and will return back to catch a new one. This is called optokinetic drum. And fortunately, we have on App Store and Play Store an application called optokinetic drum or visual assessment with optokinetic drum. You can search for and we can use it by our smartphones, looking at the child or asking him to look at the screen, and we'll never ask him anything more. We'll just keep looking at his eye. If we saw this reflex of following the object and returning back, this is a positive optokinetic drum test, and this means the child can see well. Other forms of testing is preferential looking. And fortunately, again, we have these tests available on our smartphones. If you looked at App Store or Play Store and just tried preferential looking test, you'll have many applications with these figures. And it depends mainly on having cards with two contrasting pictures, one with stripes or a bright picture like this one. And we will show the child if he can move his eye to fix the contrasting one. This means he can see well. So the preferential looking test is very important to assess for visual acuity in children. After the age of 2 years, the child will start matching pictures. So if we have in our clinic like large chart like this one or in projector in our hospitals, we can ask him to look at the distant object, and we have a similar card with similar pictures in his hands, and to tell us what is the similar one to this circle, or what is the similar one to this apple, or this rectangle, or this home, or this rabbit, or fish, or etc. So we can ask him to match pictures from distance to near. And after age of 3, the child now is mature enough to nominate the object. So I can ask him, what is this shape? He will call it elephant, or this is a check, or this is a butterfly. So I can ask him later on by nominating the pictures. Age of 4, mostly he's going to kindergarten or school. So he can tell me the letters, or he can tell me the direction of the opening of each one of these symbols, or he can say, what is the name of these pictures? Fourth topic to discuss today is nasolacrimal duct obstruction. And actually, we all know about it. Nasolacrimal duct obstruction is a very common situation. We usually meet in newborn babies. And usually it presents with lacrimation, eye discharge or recurrent eye discharge, sometimes eye swelling and lead inflammation, what we call blepharitis, and many cases may be complicated by having these swellings like dactyocele or cystic swelling of the lacrimal sac. Let's start from the beginning. What is the lacrimal outflow system? It starts with puncti on the interior of the eyelid, then passing by the canaliculi that will collect tears into this lacrimal sac that will end up in nasolacrimal duct, which opens in the inferior turbinate. So the main part of the nasolacrimal duct is hidden behind the skull bones in this place. Usually, the nasolacrimal duct is occluded till the age of 9 months of gestation and starts to open by the age of 9 months of gestation till the age of 9 months of life. So if the child has delayed opening of the nasolacrimal duct, he will come with these lacrimation, recurrent inflammation, lid swellings, and etc. So what we do? First thing, we have to rule out what we call punctal occlusion. Some cases are born with occluded puncti, and this is the shape of the occluded punctum compared to this one open punctum. So we just have to invert the eyelid to see the opening of the punctum. If it's there, okay. If it's not there, this is a punctal occlusion. It's not nasolacrimal duct obstruction. Second is we have to rule out nasal obstruction. Many children are born with nasal obstruction by adenoids or deviated septum or recurrent allergy with inflammation of the nasal mucosa that may cause secondary occlusion of the nasolacrimal duct. So it's nonsense treating the obstructed or narrow nasolacrimal duct without searching for nasal obstruction to search for a secondary cause. If we ruled out the secondary causes of nasolacrimal duct obstruction like absent punctum or occluded punctum or nasal obstruction, then we have to wait till the age of 9 months before doing surgical intervention for treating nasolacrimal duct obstruction. And until that time, we can go for conservative treatment like giving topical antibiotics, frequent lead hygiene with cleaning of the discharge, and we can start our hydrostatic massage. So how can we do our hydrostatic massage? It's very important to tell because we have to teach mothers how to do it properly. The proper way to do hydrostatic massage is pressing on this lacrimal sac because many mothers are doing it in a wrong way, pressing down over the nasolacrimal duct. And actually the nasolacrimal duct is hidden behind this nose and this nasal bone. So if we are pressing against this bone, nothing will go by our force to the nasolacrimal duct. The second important tip is to consider the lacrimal sac is situated between these two lacrimal crests. So it's in a very shallow groove between these two cresty bones. So to do, we have to know this is the wrong way to do nasolacrimal duct or lacrimal sac massage by pressing over the nose. Actually, nothing of our force will be conducted to the nasolacrimal duct. And this is the proper way to do it, is to locate the place of the lacrimal sac just above this tendon. We can press the outer canthus out. Then we can press over this lacrimal sac above the medial tendon just to press the discharge inside that sac. It will be pushed down by force to open the closed nasolacrimal duct and to get out its discharge to accept clearance of more tear film. Our last topic is how can we assess for alignment of both eyes and how to rule out strabismus. Our first test to use is Hirschberg corneal light reflex test. Usually we do it using our pen light torch. It shouldn't be very high intensity or low intensity. It should be located at about 30 to 50 centimeters from the child's eyes, and it should be on the same side of the patient's eyes and on the doctor's eyes. So I have to ask the mother to hold the child to focus on the child's eyes with a pen torch or pen light. We are searching for centration of the light reflex, like in this one. We can see this is the light reflex on the cornea. It's centered on the pupil and it should be central on the other one. If it's deviated on that one, like in this picture, it's located on the temporal edge of the pupil. So this means the eye is deviated in. This is esotropia. It may be located on the outer edge of the pupil. This is exotropia. It may be on the lower edge of the pupil. This is hypertropia, or maybe on the upper edge of the pupil, it's hypotropia. So the Hirschberg test is very easy to do, and it's meant to do assessment of centration of the corneal light reflex to assess the presence or absence of manifest strabismus. Second test is cover test. How to do? Usually we are asking the child to look at a non-accommodative target like a toy, and then we can cover the fixing eye with our hand or our opaque cover like this one. So asking the child to look at a target, this eye is occluded now, he will be forced to fix with the other eye. If we can see the other eye is moving to fix the object, this means it was originally deviated. So this means this patient has manifest strabismus in the other eye. We have latent form of strabismus or hidden form of strabismus. Like if we looked at the child's eyes, we'll see very well aligned eyes. But if we put a cover in front of one eye, the eye under cover will deviate out, in, up, or down. So this means he has latent deviation. He has tendency to deviate, but he's controlling by his brain. This is called latent or hidden strabismus. After searching for ocular balance by Hirschberg corneal light reflex test, cover test, uncover test, we have to search for motility defects. We are asking the child to look straight ahead if he's cooperative, and we can see the alignment or balance between both eyes. Then we'll ask him again to look at the other different 8 directions of gaze, like up, down, up right, up left, down right, down left, and straight left, straight right. When the child is using his eyes to look at different directions of gaze, we are looking at any limitation of motility, overaction, like if one eye is overshooting over the other one, nystagmic movement, or palpebral fissure width changes if it's coming narrower or wider, or if we have any globe retraction upon a certain. Thank you very much. I hope you enjoyed the video and you made any benefits from seeing this lecture. Thank you very much.